our next speaker hopefully is around, Hannah.
Yeah.
Hannah is going to give us the drug chat.
The download on drugs.
What we call it? Is it called download on drugs? Oh, I don't know.
Download on drugs.
Download on drugs.
Hannah is an amazing specialist pharmacist in diabetes. Is that your proper title, Hannah?
Obviously, yeah.
Special, something like that. So before you get started, we have a couple of questions to ask you.
Yeah.
Are you going first, Amanda?
Yeah, maybe. Let me find it in our little group chat. We've been having a group chat the whole way along this, saying, what are we going to ask? What are we going to ask? So we've got a maths question for you. Okay.
I still count on my fingers, guys.
So get your pen out. You need to do your calculation. So,
oh my God.
Take 10 units of basal insulin and an average of 4 units 3 times a day of their fast-acting insulin. How many subcut needles do they need in a month?
Oh my God, guys, that's horrific. I'm going to pass on that. This is, yeah, oh my God. I don't even have time to write that down. I've got no pen. I'm panicking. I'm not answering it. I'm abstaining. I'm sorry. It's far too difficult.
Basically, 4 injections a day. How many needles is that? So you would go like
4 times 28 or 4 times 30.
Yeah.
That was mean. I'll let Beth ask you another one.
Oh,
okay.
mate.
Our second question was, what was your favourite game when you were a child? That's much easier.
Oh, favourite game. Definitely Monopoly. What does that say about me?
That's so funny.
My brother was always cheating though. He'd always get Park Lane and Mayfair, and I'd always end up losing, and I just assumed
he'd be on Old Kent Road.
Yeah.
Oh, well, we'll let you get on with your slides. We're sorry we were mean.
Don't you
worry. Sorry, really.
I know you're not.
Sorry in the slightest. All right.
Okay. All right. So my session today is on download on drugs. I've covered both type 1 and type 2. So hopefully everybody will get something out of this. First of all, I just wanted to have a quick chat with everybody about how do we choose what medicines we're going to use. It's a discussion between us and the people who are on the medications, and I think just a little bit of detail around how do we end up coming to the conclusions that we do about what's going to be right going forward. So obviously it's a weighing that risk benefit piece. So we have a look at what our up-to-date evidence is of both risk and what the evidence is around the benefits, and then we have a look at what we call post-marketing surveillance. So once a drug hits the market, what happens is that it obviously has the evidence from the trial on adverse effects and benefits, but afterwards we have a look at what's going on in a bigger population. Once the drug gets released, there's only a certain number of people who are part of the trial, although the trials are very large. And that post-marketing surveillance piece, where we have a look at anybody who reports any side effects after the fact, is when rarer side effects potentially come to the fore. And I've put a little picture here of a yellow card, so this can be accessed by anybody. So if anybody has any side effects with medications, you can actually self-report those, and your healthcare professional can help you report them as well. Normally what we do is we say that if something is very new to market, it's a very new class of drug, or it's a new medicine altogether, they go into what we call a black triangle drug, which means we need to report every single side effect. Whereas if they've been around for a little bit longer, then we just report the ones that are severe, rare, unusual, those sorts of things. We need to think about what the ability of someone to take the medication that we've prescribed to them. So we need to have a think about how what people want. So that might be something along the lines of, would somebody rather take something once weekly versus once daily? Can we do assessments on dexterity? Are people able to use the devices that we've given them? All of these things come into it. And that's very much a discussion between ourselves and the people who are managing the diabetes. And I rely heavily upon those discussions being honest and open, and that adherence. So are you able to take your medicines? And if you're not, please tell us, because then we can do something about it. I think sometimes there is a culture that we don't get those relationships built up early on. So actually for us, it's really important that we're on the same page. And I'm never shocked at what people tell me about what they're experiencing with medicines, and I'd rather know, and then we can move forward and use things effectively, and we can find different things. So there's lots of ways that we can mitigate intolerable, oh my God, I can't say that word, any side effects. So we can use ways of slowing down titrations. We can have a look at putting safety nets in place to try and help people. So all of these things are things that we can work together to get you the right medications. So next slide. I can get onto my next slide. That would be helpful. Okay. Oops. So first of all is metformin. So metformin is used for type 2 diabetes. So how does it work? So it reduces the amount of glucose made by your liver, and it increases the amount of sugar that the body can use as fuel. So altogether, those blood glucose goes down. So it slows the speed at which the glucose gets absorbed as well. So so it means that your body has a little bit more time, a little bit more wiggle room, if you like, to respond to any incoming carbohydrate sugars. So what side effects might you get with metformin? So tummy upset is a really common side effect with metformin, and the way that we mitigate some of that is that we do a nice slow titration, and sometimes we need to slow it down even further than what our normal guidelines would be. So often what I'll do with people who haven't tolerated a previous dose is we'll slow the titration right down, we'll go back to the previous tolerated dose, and we'll go slower. So it's normally a weekly titration. If we then slow it down to every couple of weeks, sometimes that just gives the body a little bit more time to get used to that medication. So it can cause vitamin B12 deficiency, metformin, particularly if you've been taking it for a long period of time. This is something that needs to be checked annually, and it's actually something that can be missed. So it's important that you advocate for yourselves in some ways and make sure that that's done, as well as healthcare professionals making sure that that's done as well, because we're a team. So what do you need to do if you get ill, if you're taking that medicine? So you may need to withhold it, and sometimes that needs to be a discussion between you and your healthcare provider. If you've just got a bit of sniffles or colds, normally not necessary. However, if you're profoundly ill, particularly if you've got vomiting, diarrhea, where you're getting a bit dehydrated, then sometimes we just ask you to just withhold that medication for a little while. Taking it with food, again, can mitigate those side effects, give you a bit of stomach protection to the medication. So in those regards, sometimes it's better tolerated. There are modified release forms of metformin. So that again can mitigate the side effects, those tummy upsets, etc. We have to be careful with our dosing. Sometimes people think that because it's a modified release, we can take it all together as one dose in the morning, which I've seen multiple times. And actually, it still needs to be spread out during the day, so that you get the maximum benefits to be able to manage the blood glucose 24 hours a day. So and some metformin is better than none. So there's lots of evidence around metformin being protective for the heart, and it's actually beneficial at any dose. It appears that the evidence suggests that even if you're on just one tablet a day of metformin, you still get those heart benefits. So a good all-rounder drug. Sulfonylureas is my next class. So this is gliclazide, glipizide, gabencamide, and tolbutamide. So lots of different ones. Some are short-acting, some longer-acting ones. So there's lots of choice, and we like that. We like choice. We like to be able to decide, is it easier for us to take it once a day? Is it better to have that flexibility where we can dose differently in a morning to an afternoon? Those are the sorts of things that we're thinking about here. So sulfonylureas is basically wrings out your pancreas to produce a bit more insulin. So you still have to have that beta cell production, that beta cell function. And what side effects might you get? Hypoglycemia is the main one here, and you do get weight gain with sulfonylureas. So again, what would you do if you're poorly and you're taking this? Increasing monitoring is absolutely essential when you are poorly, and obviously if you're not eating and drinking, normally your sugars can drop, but also illness can rise your sugars. So you never quite really know where the balance is going to bottom out. So it's important that monitoring is there so you can take appropriate action. Again, taking with meals, is important, and you need to know the rules and regulations on driving. Obviously, once we start getting into things that cause hypoglycemia, your DVLA guidance comes in, and there are trend leaflets associated with that, and again, a discussion with your healthcare professional should occur regularly. I think if you get told so many things, and sometimes it's that repeated listening on some of these points that's important, because I definitely remind myself regularly as well. So we discuss any occupational barriers. So if you are, for example, a long distance lorry driver, that might have significant impact on what you're able to do and the action that you need to take while you're driving. And I've said already that there are longer and shorter acting. SGLT2s are a newer class of medicine. So how does it work? So basically it blocks the receptors that reabsorb sugar. So our kidneys are very good at retaining sugar as much as we can. So we actually block that, and then our kidneys actually release the glucose out in your urine at much higher levels than they normally would. They also have a protective effect on the kidneys, and there's lots of benefits in protecting your heart as well. Side effect wise, it's a bit of a plethora of side effects, but again, this mitigation of side effects, this working against the side effects in order, we can easily safety net ourselves. And these medications have so many benefits that actually doing this can be more important than not being on the medicines. So they often can cause genital fungal and bacterial infections, and very rarely diabetic ketoacidosis. This can happen when your blood sugars are actually normal. So we need to make sure that you're aware of the side effects, and I'll talk about that in a little while. They can make your cholesterol levels increase. Actually, this is actually listed as a common side effect, and I do see it. And the bottom line on this is these are such beneficial drugs to your heart and for your kidneys, and often those are the reasons why we're using it, as well as getting good glycemic control with no weight gain. That what we will do is we'll just manage your cholesterol around that. So if your cholesterol goes up, we would manage that with statins, or if it's still within a decent range, then we'll just monitor you. There is a slight potential increase in amputation risk. This is still hotly debated, mainly because the risk came out of really one trial, and we're still debating whether this is a thing. Even a follow-up trial for the same drug seemed to not show the same effects as previously. People with diabetes are at higher risk of amputation anyway, so it's potentially that it was a population that was already at high risk, but that doesn't mean that we can't do things to minimize that, even if we are worried. And one of the things that we need to do is do regular foot checks, and I know that we'll be talking about foot health later, so I'll not go into that. Again, what do you do when you're ill? So stop the medication if you get very poorly again, and seek advice from your healthcare team. We need to be monitoring blood glucose as usual, and making sure that we're not going high. These drugs are highly efficacious, so if they are stopped, your blood glucose can rise quite significantly. So we need to make sure that we're on top of sort of a backup plan, if you like. Top tips, they often promote weight loss, and you need to keep good genitourinary hygiene, check your feet, keep well hydrated. That's really important. These drugs can lower your blood pressure, so actually some minor adjustments might need to be made on your normal blood pressure medication, or it might mean that we can kill two birds with one stone, in the sense that we might be able to manage your blood glucose as well as managing your blood pressure. So just a quick one about good genitourinary hygiene. Everybody should do this anyway. So I'll just quickly go through this as a Trend UK leaflet for people with diabetes, and this should be something that people are following anyway at higher risk anyway, even without SGLT2s. So ladies, we want to try and avoid the use of deodorants and perfume products in and around your intimate areas, changing tampons, panty liners as frequently as possible, and ensuring you wipe from front to back when going to the toilet. Changing your underwear after swimming and working out is important. Try and avoid really roasting hot baths, and then you might want to check if you feel that something is going awry. With gentlemen, again, cleaning your penis after passing urine and drying it properly. If your partner has vaginal thrush, sometimes that can be that can promote fungal infections in males, so you might want to use a condom, or avoiding those perfumed soaps or shower gels. Wearing that loose fitting underwear as well, very tight underwear, is probably not the way to go. So also just picking up on the point that in very rarely these drugs can cause what we call a normoglycemic, so normal sugar DKA, so diabetic ketoacidosis. So know your signs, so feeling sick, abdominal pain, those deep breaths, sighing breaths, frequency of passing urine, thirst, rapid weight loss and drowsiness, and take action immediately. So if you're unwell, rest, drink loads of fluids, and then report any symptoms of DKA, because that is a medical emergency. Increase your monitoring, so know what's going on with your blood glucose as well, and you might need to withhold the medicines, particularly if you're going in for a surgical procedure, or if you've got an acute illness. This is a mouthful. So this is a class of drugs called thiazolidinediones, and pioglitazone is the only one left in this class. So these drugs are very, very good for people who have what we call non-alcoholic fatty liver disease, because they make your body very sensitive to insulin. So they can be very beneficial particularly for people with central weight gain, where it's kind of sits around your tummy area. If you've got, what side effects might you get? You might get weight gain, is a major thing with this, sometimes up to 4 kilos of weight gain. So it can be it feels a little bit counterintuitive. Also, there is a link to fracture. And I would certainly want this medication reviewed in any post-menopausal women, and a risk benefit done on that. These drugs should be reviewed if you develop any heart failure, and this drug should be reviewed if you have any signs or symptoms of bladder cancer or active disease. Again, it's not something that is a great worry. I think that lots of evidence around that now to say that it's not really a worry, but I think nevertheless we will want to have those discussions with you. DPP-4s, how do those work? They increase insulin secretion, decrease the amount of new sugar in the body, and very rare side effects. These are things like linagliptin, sitagliptin, allagliptin. Sometimes we use these as our minor adjustment medications. They're not hugely efficacious, but they are things that can be quite useful. Also, they're useful in people with renal impairment, so they work very effectively for people with renal impairment, in the sense that we can use them to quite low EGFR, so we can use them really low in kidney disease. So as your kidneys potentially decline with age, etc., these medications you can stay on for a long time, or until dialysis in some cases. So for that point, that is good. It's weight neutral, so doesn't add any weight on, and we would say that you wouldn't normally use these with GLP-1 agonists, which we're coming on to now. And I'm zipping through. I've got a feeling that I'm running over time. So how does it work? So increases insulin, so GLP-1, so these are your injectables. We're starting to get into injectable therapies now, and these are liraglutide, lixisenatide, semaglutide, dulaglutide, and exenatide. And what these do is they increase the amount of insulin you produce. They make you feel really full, and they reduce the amount of sugar your body produces. So what side effects can you get? Very common to get gastrointestinal side effects, so diarrhea, feeling a bit nauseous, particularly at the beginning. So often you build up a bit of a tolerance to it, and we again do a slow titration on these medications. Very rarely it can precipitate acute pancreatitis, and this will often present with abdominal pain, nausea, vomiting, and diarrhea. And this is about us just having that chat about being very aware of the symptoms of acute pancreatitis. So if it does happen, but like I say, this is very, very rare side effect. Top tips, they often promote weight loss, so that's very beneficial, some more efficacious on that than others, and that, like I say, you can have weekly or daily injections depending on which medication you choose, and it gets you used to doing some injections. So if you have type 2 diabetes and you are going to want to go onto insulin at some point, then sometimes this is quite a good primer for that. Some people might be non-responders. So some people you put on these medications and they just don't respond at all. You don't get the benefits that you would normally see. And in those situations, we just need to stop it and try something different. Insulins, so lots and lots of insulins, and I'm sorry I just don't have enough time to go through all of these today, but there's lots of different insulins and there's lots of different times that you need to take those insulins. There are mealtime insulins, and then there are your long-acting basal insulins. You all know this very, very well, and these are the things that we need to think about, is that, are you getting them the right time? I know that we've got a session later on about about keeping yourself safe in hospital. Sometimes these are the times when things become a bit difficult about making sure that mealtime insulins are taken with meals, particularly the ones where you have to take them 30 minutes before your meal. When you have no control over when that meal is coming, that can cause some difficulty. So it's about having those discussions with people in the hospital environment about what sort of insulin and when you need to be taking them. Insulin profiles. So I just wanted to have a quick chat about this. So lots of different profiles, and we use these to try and match you as best as we can to what's happening. So we use this in combination with your blood glucose readings. So whether that be from continuous blood glucose monitoring, or whether it be from your Freestyle Libre, or whether it be from your capillary blood glucose, or your fingertip testing. And we'll try and get all that information and then match your insulins as best as we can. And you can see here we've got rapid. I've just taken two profiles. So rapid acting insulin, you get this high peak, which covers this really quite rapid rise in blood glucose after you've eaten, and then it's quickly out again. And we've got some even more rapid insulins now that are coming to market, where they're even faster in and faster out. So it matches really closely with that meal that you're having. And that's still the same if you've got a pump on, you would bolus usually your rapid acting insulin, quick in, quick out. Your long-acting analog, so is a much flatter profile here, and there are loads of very long-acting insulins now that are coming to market that have an even flatter profile. That means you've got a nice steady rate that insulin is releasing, which means it covers your normal body. If your normal body would produce this sort of background insulin level just to keep you ticking over. Lots of other medications, which I don't think I'm going to have time to go into, but it's a balance. So we have to think of people as not just about managing glucose, it's about managing blood pressure, cholesterol, neuropathic pain in some cases. There might be medications for emotional health, and it's about balancing all these things. Often many of you will be on a multitude of medicines, and sometimes it's not about what each individual medicine does, but what that whole picture looks like for you. We'll try and put you on dual medications where possible. We'll try and get you onto whatever works best for you. With blood pressure, there are ACE inhibitors and ARBs. This is normally our first go-to blood pressure tablets. So these are things like Ramipril, losartan, so your prils and your sartans. These are the ones that we normally go to, and that's because they give some protection for your kidneys. So these are the ones that we would preferentially use in people who are living with diabetes. Cholesterol management is so important, and often things don't necessarily get titrated, and we need to think about that. So very important to get those different elements brought together, and particularly with cholesterol, lots of evidence that people living with diabetes at high cardiovascular risk, and cholesterol is your big money things. It's one tablet once a day, and actually what you get out of taking that one tablet once a day is probably the most beneficial thing to preventing any complications for yourself down the lines. I think I'm going to stop there. Beth and...
We're coming back.
Thank you. I'm sorry, I'm so over.
You're fine, you're fine. I think we might run over a tad past 12 today, but it's fine. We've got a few questions to ask you.
Yep.
One of our type 1s is asking, I take metformin because I'm insulin resistant. Can you tell me about how that works with in type 1 diabetes?
Yeah, so metformin traditionally we did used to use quite a lot. So I'd see it less now, actually. I don't know about you girls, you since you're here might as well, but I don't see it as much these days. But it definitely does sensitize to the insulin. I think again we're thinking about doing this the similar sort of idea with using some of the other medications as well alongside of insulin. So it's heard of. There's nothing wrong with it. It's not, the thing is with metformin, it's a beautiful drug in the sense that it's very well tolerated on the whole, and it doesn't cause hypo. So your hypo risk would just be from whatever insulin you're on alongside of that. So I think it's a perfectly legitimate thing to be on alongside of your insulin. Plus you're getting that heart protection as well.
Yeah, so we had a similar question as well about, like you mentioned, other medications, so SGLT2s, GLP-1s, that kind of thing. So it's important to say some of the medications you talked about are just licensed for people with type 2, but SGLT2s do have the type 1 license. So what are your thoughts in SGLT2s in people with type 1 diabetes?
So yeah, I think this is a major area that will come to the fore as we go forward, particularly because there are now trials being done with the SGLT2s in populations that don't even have diabetes for other reasons. So we might want to use them to protect your kidneys, and just to protect your kidneys, not necessarily for the glucose benefits. And then in addition to that, you've got the fact that you've got this cardiovascular benefit as well, particularly around heart failure for these medications. And again, trials have been done in people who don't even have diabetes. So they might be used for that, or it might be to insulin spare, so that we can try and reduce the amounts of insulin requirements. Obviously with insulin, you're going to get problems with weight gain, etc., etc. Those are some of the reasons, but they're extremely good for both type 1 and type 2. You just need to be cautious about the DKA risk. Obviously that's going to be need to be carefully monitored.
Yeah, so we've tweeted all the DKA 6-day rule stuff out from our account. So again, if anyone is worried about 6-day rules, never heard of them, that kind of thing, do go to our Twitter page because we've tweeted all the stuff out. So hopefully people have got hold of those. Got another question?
So we've got one more question. GLP-1s, are they safe to use if you are TTC? Now, I did not know what TTC was, but I've been informed that this is trying to conceive.
Yeah, you're not doing that.
Excellent question. So I would say that needs to be on a case-by-case basis. They certainly won't be licensed for that. Normally licenses would only be given for people who have had a trial in that medication. As far as I'm aware, although I don't do a lot of work in pregnancy or antenatal. So my feeling would be that would be something that would need to be reviewed. And obviously normally people get switched to insulin who need a bit more help and support, and that tight control is very important if you're trying to conceive, to reduce your risks of any.
I'm just thinking when you're pregnant, you've got enough reflux as it is, let alone without.
Yeah, absolutely. Oh God, you're taking me right back now.
Yeah, exactly. That's it. Yeah, I would imagine it's a bit not used that often, but again, like you said, it's case.
Right, thank you very much, Hannah. That was fantastic.
Thank you, guys.